Hello everybody. Today we are going to discuss the guidelines of subarachnoid hemorrhage which are published in 2023. So in patient with this aneurysmal subarachnoid hemorrhage, the use of clinical scale like Hunt-Hess grade or World Federation of Neurosurgical Society grade is recommended to determine initial clinical severity and predict the outcome. In patient with the acute onset of severe headache, prompt diagnostic workup and evaluation are recommended to diagnose and exclude aneurysmal SAH and to minimize the morbidity and mortality. This has class of recommendation 1 level of evidence B. In patient with acute onset of severe headache who present to us for more than 6 hours from the symptom onset or who have new neurological deficit, non-contrast head CT, non-contrast head CT is recommended. And if it is a negative for aneurysmal SH and if the duration of this headache was more than 6 hours, then we should directly go for lumbar puncture to diagnose and exclude the aneurysmal SH. Again, this statement has the class of recommendation 1 level of evidence B. In patient with acute onset of severe headache who presented to us within less than 6 hours of period from symptom onset and without neurological deficit, a non-contrast head CT should be performed on high quality scanner and interpreted by board certified neuroradiologist uh, is and it is a reasonable to diagnose and exclude SAH. This has class of recommendation 2A level of evidence B. In patient with acute onset of severe headache without new neurological deficit, then um, uh, then uh, uh, then we should apply the Ottawa SH rule to identify those who are at high risk of SH. This statement has a class of recommendation 2B and level of evidence B. So in patient with spontaneous subarachnoid hemorrhage with the high level of concern for aneurysmal source and negative or inconclusive CT angiography and digital substantial angiography, it is indicated to diagnose or exclude cerebral aneurysm. This has class of recommendation 1 level of evidence B. In patient with SH from the confirmed cerebral aneurysm, DSA can be useful to determine the optimal strategy for aneurysmal intervention. This statement has class of recommendation 2A level of evidence B. Now we will see what is this Ottawa rule. For alert patient of more than 15 years of age who has new severe non-traumatic headache reaching maximum intensity within 1 hour, the patient require additional investigation for SAH if they meet any of the following criteria. Like age more than or equal to 40 years, then any evidence of neck pain and stiffness, witness loss of consciousness, onset during exertion, then thunderclap headache and limited neck flexion on examination. Then we'll see what is the workflow of patient with the symptom concerning for SAH. If the patient presented to us with acute onset of headache and if the patient doesn't have any neurological deficit, then apply the Ottawa rule. Ottawa rule. This statement has a class 2B recommendation. And if the headache is less than 6 hours and no new neurological deficit, then go for a non-contrast head CT. In non-contrast head CT, if SH is there, then we need to go for CT angio and DSA to determine the optimal treatment strategy. If CT does not show any evidence of SH, then we should work for the other diagnosis. If the headache is of more than 6 hours of duration and presented or if there are new neurological deficit, then then also first you have to go for non-contrast head CT. If non-contrast head CT showed the evidence of SAH, then we need to go for angiography to determine optimal treatment strategy. If if CT doesn't show any evidence of SAH, then next investigation, and if the onset of headache is more than 6 hours, then the next investigation is lumbar puncture. If lumbar puncture shows the evidence of xanthochromia, then we should work up xanthochromia, then we can go for the CT angiography and DSA. If lumbar puncture do not show any evidence of xanthochromia, then we need to think about other differential diagnosis. For patient with the aneurysmal SH, the timely transfer from the hospital with low case volume to the high volume center with multidisciplinary neurointensive care services, comprehensive stroke center capabilities, and experienced cerebrovascular surgeon and the neuro endovascular intervention interventionalist is recommended to improve outcome. Class of recommendation 1, level of evidence B. For patient with aneurysmal SAH, care should be provided in a dedicated neurocritical care unit by multidisciplinary team. This has a class of recommendation 1, level of evidence B. In patient with the aneurysmal SAH and the unsecured aneurysm, frequent blood pressure monitoring and BP control with short-acting medication is recommended to avoid hypertension, and BP variability. This has class of recommendation 1, level of evidence C. In patient with aneurysmal SAH who are receiving anticoagulant, emergent anticoagulation reversal with appropriate reversal agent should be performed to prevent rebleeding. This has a class of recommendation 1, level of evidence C. In patient with aneurysmal SH, routine use of antifibrillary therapy is not useful to improve functional outcome. This has class of recommendation 3, level of evidence A. So now we'll see what is surgical and endovascular methods for the treatment of ruptured cerebral aneurysm. For patient with the aneurysmal SH, surgical and endovascular treatment for the ruptured aneurysm should be performed as early as possible after presentation within 24 hours of onset to improve the outcome. This treatment has class of recommendation 1, level of evidence B. For patient with aneurysmal SAH, complete obliteration of ruptured aneurysm is indicated whenever feasible to reduce the risk of bleeding and the retreatment. Again, this has class of recommendation 1, level of evidence B. For a patient with aneurysmal SAH, in whom complete obliteration of ruptured aneurysm by either clipping or primary coiling treatment is not feasible in acute phase, partial obliteration to secure rupture site and retreatment in a delayed fashion in those with the functional recovery are reasonable to prevent rebleeding. This has class of recommendation 2A and the level of evidence C. For patient with aneurysmal SH from the ruptured aneurysm of the posterior circulation that are amenable to coiling, then the coiling is indicated in preference to clipping to improve outcome. Class of recommendation 1, level of evidence B. For patient with aneurysmal SH, which are deemed salvageable with depressed level of consciousness due to large intraparenchymal hematoma, then the emergency clot evacuation should be performed to reduce the mortality. Again, this statement carries the class of recommendation 1, level of evidence B. For patient with aneurysmal SH, the ruptured aneurysm should be evaluated by specialist with endovascular and surgical expertise to determine the relative risk and the benefit of surgical and endovascular treatment according to patient and aneurysmal characteristic. This statement carries the class of recommendation 1, level of evidence C. For patient of more than 70 years of age with SH, the superiority of the coiling and the clipping to improve outcome is not well established. This statement carries the class of recommendation 2B and level of evidence B. Now, for patient who has less or who are presented to us with age less than 40 years of age with SH, clipping of a ruptured aneurysm might be considered the preferred mode of treatment to improve durability of the treatment and outcome. Again, it has a class of recommendation 2B, level of evidence C. For patients with good grade SH from ruptured aneurysm of anterior circulation, who are equally suitable for both primary clipping and coiling. The primary coiling is recommended in preference to clipping to improve 1-year functional outcome. This statement has class of recommendation 1, level of evidence A. For patients with good grade SH from ruptured aneurysm of the anterior circulation, who are equally suitable for both coiling and clipping, both treatment options are reasonable to achieve favorable long-term outcome. This statement has a class of recommendation 2A and level of evidence B. For patients with aneurysmal SH from the ruptured wide neck aneurysm are not amenable to surgical clipping or primary coiling, endovascular treatment with the stent-assisted coiling or flow diverts is reasonable to reduce the risk of rebleed. This statement has a class of recommendation 2A, level of evidence C. For patient with aneurysmal SH from the ruptured fusiform and blister aneurysm, the use of flow diverters is reasonable to reduce the mortality. This statement has class of recommendation 2A and level of evidence C. For patient with aneurysmal SAH from the ruptured saccular aneurysm is amenable to either primary coiling and clipping. Stent or flow diverters should not be used to avoid the high risk of complication. This statement has a class of recommendation 3, level of evidence B. Then the use of anesthetic management for surgical and endovascular treatment of SH. In patient with aneurysmal SH, intraoperative use of the mannitol and hypertonic saline can be effective in reducing ICP and cerebral edema. This has class of recommendation 2A, level of evidence B. In patient with aneurysmal SH, anesthetic goal should include minimizing post-procedural pain, nausea, vomiting. This has a class of recommendation 2A, level of evidence B. In patient with aneurysmal SH, prevention of intraoperative hyperglycemia, hypoglycemia during aneurysmal surgery is reasonable to improve outcome. This statement has class of recommendation 2A, level of evidence B. In patient with aneurysmal SH and unsecured ruptured aneurysm, frequent intraoperative BP monitoring and BP control are reasonable to prevent ischemia and re-rupture. This statement carries the class of recommendation 2A, level of evidence C. Now, recommendation for anesthetic management of surgical and endovascular treatment of SH. In patient with aneurysmal SH, intraoperative neuromonitoring may be reasonable to guide anesthetic and operative management. Class of recommendation 2B, level of evidence B. In patient with aneurysmal SH and uncontrolled intraoperative aneurysmal rupture, adenosine may be considered to facilitate aneurysm clip placement by inducing cardiac standstill and temporary profound pause. This has class of recommendation 2B, level of evidence C. In patient with a good grade SAH, the routine use of induced mild hypothermia during aneurysmal surgery is not beneficial. This has class of recommendation 3 and level of evidence B. Now, management for medical complications associated with SAH. In patients with aneurysmal SAH who require mechanical ventilation for more than 24 hours, implementation of standardized ICU care bundle is recommended to reduce the duration of mechanical ventilation and hospital-acquired pneumonia. Class of recommendation 1, level of evidence B. Now, in patient with aneurysmal SH who develop severe ARDS and life-threatening hypoxemia, rescue maneuver such as prone positioning and the alveolar recruitment maneuver with ICP monitoring may be reasonable to improve oxygenation. Class of recommendation 2B, level of evidence B. In patient with aneurysmal SH, close monitoring and goal-directed treatment of volume status are reasonable to maintain euvolemia. Class of recommendation 2A, level of evidence B. In patient with aneurysmal SH, the use of mineralocorticoid is reasonable to treat natriuresis and hyponatremia. Class of recommendation 2A and level of evidence B. In patient with aneurysmal SH, induction of hypervolemia is potentially harmful because of the association of excessive morbidity. Class of recommendation 3, level of evidence B. In patient with the aneurysmal SH, whose ruptured aneurysm have been secured, pharmacological or mechanical venous thromboembolism prophylaxis is recommended to reduce the risk of venous thromboembolism. Class of recommendation 1, level of evidence C. In patient with the aneurysmal SH, the effective glycemic control, strict hyperglycemia management, and avoidance of hypoglycemia are reasonable to improve outcome. In patient with aneurysmal SH with fever refractory to antipyretic medication, the effectiveness of therapeutic temperature management during acute phase of aneurysmal SH is uncertain. The class of recommendation 2B, level of evidence C. In patient with the aneurysmal SH, the use of evidence-based protocol and the order set is recommended to improve standardization of the care. Class of recommendation 1, level of evidence B. In patient with the aneurysmal SH, the frequent neurological assessment and the neurological assessment tools such as GCS and the National Institute of Health Stroke Scale is recommended to monitor delayed cerebral ischemia and other secondary complications. Class of recommendation 1, level of evidence B. In patient with the aneurysmal SH, the frequent vital sign and the neurological monitoring is recommended for detection of neurological change and the prevention of secondary cerebral insult and the poor outcome. Class of recommendation 1 and the level of evidence B. In patient with the aneurysmal SAH, the validated dysphagia screening protocol should be implemented before initiation of oral intake to reduce the incidence of pneumonia. This has class of recommendation 1 and the level of evidence B. In patients with the aneurysmal SAH, specialized nursing stroke competencies and certification can be effective to positively affect outcome and timeliness of care and adherence to the stroke protocol. Class of recommendation 2B and level of evidence C. In patients with aneurysmal SAH and the secure aneurysm, an early and evidence-based morbidity algorithm uh, mobility algorithm is reasonable to improve level of function at discharge and the global function outcome at 12 months. The class of recommendation 2A and C. Now the monitoring and detection of cerebral vasospasm and delayed cerebral ischemia. In patients with the aneurysmal SAH and the suspected vasospasm or limited neurological examination, CT angiography and CT perfusion can be useful to detect vasospasm and predict the delayed cerebral ischemia. This has class of recommendation 2A, level of evidence B. In patient with the aneurysmal SAH, transcranial Doppler ultrasound monitoring is reasonable to detect vasospasm and to predict delayed cerebral ischemia. Again, this has a class of recommendation 2A and level of evidence B. In patient with high-grade SAH, the continuous EEG monitoring can be useful to predict delayed cerebral ischemia. This has class of recommendation 2A and level of evidence B. In patients with the high-grade SAH, the invasive monitoring of brain tissue oxygenation, lactate pyruvate ratio, and glutamate may be considered to predict delayed cerebral ischemia. This has class of recommendation 2B and level of evidence B. Management of cerebral vasospasm and delayed cerebral ischemia after aneurysmal SAH. In patient with the aneurysmal SAH, early initiation of enteral nimodipine is beneficial in preventing delayed cerebral ischemia and improving functional outcome. This has class of recommendation 1, level of evidence 8. In patient with aneurysmal SAH, monitoring euvolemia can be beneficial in preventing delayed cerebral ischemia and improving functional outcome. Class of recommendation 2A, level of evidence B. In patient with aneurysmal SAH and the symptomatic vasospasm, elevating systolic blood pressure values may be reasonable to reduce the progression and severity of delayed cerebral ischemia. Class of recommendation 2B, level of evidence B. In patients with the aneurysmal SAH and the severe vasospasm, the use of intraarterial vasodilator therapy may be reasonable to reverse the cerebral vasospasm and to reduce progression and severity of delayed cerebral ischemia. Again, this statement carries the class of recommendation 2B and the level of evidence B. In patients with the aneurysmal SAH and severe vasospasm, cerebral angioplasty may be reasonable to reverse the cerebral vasospasm and reduce the progression and the severity of delayed cerebral ischemia. Again, this statement has class of recommendation 2B and the level of evidence B. In patients with the aneurysmal SAH, the routine use of statin therapy to improve outcome is not necessary. This statement carries the class of recommendation 3, level of evidence A. In patients with the SAH, routine use of intravenous magnesium to improve neurological outcome is also not recommended. For patients with SAH at risk of delayed cerebral ischemia, prophylactic hemodynamic augmentation should not be performed to reduce the iatrogenic patient harm. Now, this is the practical and the evidence-guided approach for the management of patient with cerebral vasospasm and delayed cerebral ischemia after SH. Patient with the acute aneurysmal SH, we should start if it is a diagnosis, then we can start with the oral nimodipine. Then we should perform the regular neurological monitoring. If a reliable for reliable neurological examination should be conducted by transcranial Doppler monitoring. And if it is unreliable, then also we should go, and if it is unreliable neurological examination, then go for the transcranial Doppler monitoring and continuous EEG. And then we have to consider the invasive multimodal neuromonitoring Then we should avoid the prophylactic hemodynamic augmentation. And if the if the patient is worsening neurologically or on monitoring, when neurological examination is unreliable, then we need to address the examination confounders like elevated blood pressure. Then we need to ensure euvolemia, and additional imaging are indicated like CT angio or CT. If patient is still worsening, then proceed for the endovascular rescue therapy with spasmolytics and angioplasty. And if the patient is not worsening, then continue monitoring. Uh, and if worsening and after spasmolytic therapy and angioplasty, if the patient continues to worsen, then we need to monitor closely. And if not, then the imaging for delayed cerebral ischemia explains the deficit, and the other explanation for examination. Now, the management of hydrocephalus associated with the aneurysmal SAH. In patient with aneurysmal SAH and acute symptomatic hydrocephalus, urgent CSF diversion should be performed to improve neurological outcome. In patient with the aneurysmal SAH and hydrocephalus who require EVD, implementation and adherence to the EVD bundle protocol that address the insertion and management education and monitoring are recommended to reduce complication and infection rate. In patients with aneurysmal SH and associated chronic symptomatic hydrocephalus, permanent CSF diversion is recommended to improve neurological outcome. In patients with aneurysmal SH, routine penetration of lamina terminalis is not recommended for reducing the rate of shunt dependency. Now, management of seizures associated with aneurysmal SH. In patient with aneurysmal SH, either fluctuating neurological examination, depressed mental status, ruptured NC aneurysm, and high-grade SH, ICH, hydrocephalus, cortical infarction, continuous EEG monitoring is reasonable to detect seizure. In patient with the aneurysmal SH and the high seizure features like ruptured MC aneurysm, high-grade SH, ICH, hydrocephalus, cortical infarction, use of prophylactic anti-seizure medication may be reasonable to prevent the seizure. In patient with aneurysmal SH without high-risk seizure features like ruptured MC aneurysm, high-grade SH, ICH, hydrocephalus, and cortical infarction, prophylactic anti-seizure medication is not recommended. The recommendation for management of seizure. In patient with SH, phenytoin for seizure prevention and anti-seizure prophylaxis is associated with excess morbidity and mortality. In patient with aneurysmal SH who presented with seizure, treatment with anti-seizure medication for less than or equal to 7 days is reasonable to reduce the seizure-related complication in perioperative period. This treatment has class of recommendation 2A and the level of evidence B. For patient with the aneurysmal SH without prior epilepsy who presented with seizure, treatment with anti-seizure medication beyond 7 days is not effective for reducing the future SH associated seizure risk. This treatment has a class of recommendation 3, level of evidence B. Then SH recovery. In patient with the aneurysmal SH, use of validated grading score and the patient reported outcome measure prior to hospital discharge is recommended to screen for physical, cognitive, behavior, and quality of life deficit. Class of recommendation 1, level of evidence B. In patient with SH, use of validated tools in the post-acute period is recommended to identify post-SH depression and anxiety. Now, the recommendation for SH during acute recovery. In patient with acute SH under depression, psychotherapy and pharmacotherapy are recommended to reduce the symptoms of depression. Class of recommendation 1, level of evidence B. In patient with aneurysmal SH, the use of validated screening tool in the post-acute period is useful to identify cognitive dysfunction. The class of recommendation 1, level of evidence B. In patient with the aneurysmal SH, early multidisciplinary team-based approach to treatment and the rehabilitation is recommended to reduce the length of stay and identify the discharge need. Now, in patient with aneurysmal SH and no other medical and the neurological contraindication, early rehabilitation after ruptured aneurysm is secured It's secured and is reasonable to improve functional outcome and reduce the length of stay. The class of recommendation 2A, level of evidence B. In patient with aneurysmal SAH in coma, early use of neurostimulant may be reasonable to promote consciousness recovery. Class of recommendation 2B, level of evidence C. In patient with aneurysmal SAH without depression, fluoxetine therapy is not effective to enhance post-stroke functional status. The class of recommendation 3, level of evidence A. In patients with aneurysmal SAH, screening and intervention for depression, anxiety, sexual dysfunction are recommended to improve long-term outcome. Class of recommendation 1, level of evidence B. In patients with the aneurysmal SAH, it is reasonable to choose MoCA over MMCSE to identify the cognitive impairment. Class of recommendation 2A, level of evidence B. In patients with aneurysmal SAH, counseling the patient and caregiver on high long-term risk of cognitive dysfunction can be beneficial to identify long-term need. Class of recommendation 2B, level of evidence B. In patients with aneurysmal SH who have undergone aneurysmal repair, perioperative cerebrovascular imaging is recommended to identify the remnant of recurrence of aneurysm that may require further treatment. This has class of recommendation 1, level of evidence B. In patients with aneurysmal SH who have undergone aneurysmal repair, follow-up cerebrovascular imaging is recommended to identify the recurrence or regrowth of a treated aneurysm or changes in another known aneurysm or development of de novo aneurysm that may require further treatment to reduce the risk of aneurysmal SH. This has class of recommendation 1, level of evidence B. Now, the risk factor for ruptured and de novo aneurysm. Now, residual aneurysm, the risk factors are incomplete aneurysmal occlusion results in higher risk of re-rupture. However, even completely obliterated aneurysm carry the risk of rupture in the long term. Now, coiled aneurysm. In case of coiled aneurysm have high rate of incomplete occlusion and recurrence and therefore have a high risk of re-rupture. Now, regarding de novo aneurysm, risk factor for de novo aneurysm in patient with ruptured aneurysm include young age, family history, and multiple aneurysm. Now, regarding growth and rupture, risk factor for growth and rupture of de novo aneurysm include female sex, shorter interval of formation of de novo aneurysm, multiple aneurysm, and large size. Thank you, guys.